Good morning. My name is Boris Arbit. I'm a cardiologist here at UCLA. And this morning I was hoping to share with you an interesting topic that is quite prevalent and I think will be of significant interest to the general population and to our audience as well, to our audience at large rather. Please feel free to keep up with us and please send your questions and use the hashtag UCLAMDChat, and you can also input them on Facebook directly, and hopefully we'll be able to get to them at the end of the talk. The talk for today, and what I really hope to delve into with some degree of depth rather, is shortness of breath. This is a complaint that is very, very prevalent in the community, very prevalent in the country, and is a significant concern for many people. When a patient presents to the office with shortness of breath, the differential or the things that are possible that are actually going on is really, really large. I thought to share a few of the things that really the physician is thinking about when they see this complaint, and this is really just beginning to scratch the surface. It could be heart failure with the reduced ejection fraction, could be heart failure with preserved ejection fraction, and we'll spend a lot of time talking about the difference between the two. Could it be the problem with the heart muscle itself? It could be an issue with the pulmonary artery hypertension where the arteries in the lungs are involved. Is it the lining of the heart that's the issue and that's causing the patients to be short of breath? Is it valvular heart disease? Is it heart disease? Is it simply the problem is the vessels are plugged or have significant disease and are causing symptoms when the patient exerts? Could it be a pulmonary embolism? A significant percentage of patients don't even know when they had an incident event of pulmonary embolism, and we simply come to find the results, the sequelae of this later on. The right ventricle of the heart is something that's really been not addressed significantly in the literature and in the common press previously because it's a very unique physiology, and that's gaining significant attention recently as well. And it could be simply something not related to the heart itself. It could be related to the lungs, as I said. It could be anemia. It could be obesity. It could be deconditioning or being significantly overweight that's causing the patient to be short of breath. It could be also other much more rare diseases like neuromuscular and mitochondrial disorders. Our focus today will be on heart failure, and specifically the two types of heart failure, reduced ejection fraction and preserved ejection fraction. The scope of the problem is very large. The disease is highly prevalent and it affects many, many patients, and it also is a significant burden on our healthcare and on our economy. Nearly 6 million Americans today have heart failure, and 1 in 5 persons over the age of 40 would be expected to develop heart failure at some point in their lifetime. The leading cause for hospitalization among Medicare beneficiaries is heart failure and heart failure readmissions. The rate of hospitalizations has only increased recently and is up nearly 160% rather. What's very important to keep in mind, both for the patients and for the physicians who are caring for the patients, is the high mortality of the disease. Often in clinic, we see patients many times throughout the year, and we don't appreciate really the significant mortality that is associated with the diagnosis. And it's actually higher than significant percentage of many cancers, with 1-year mortality of approximately 45%. Here are some projected trends for the disease. The number of patients is expected to rise over the years. This is a function of an aging population, and this is also a function of a higher prevalence of hypertension and diabetes. So as a whole, the number of patients with heart failure is expected to rise over the coming years. Heart failure is a syndrome. It's not a specific disease. It's rather a combination of several syndromes, which makes it a little bit more challenging at times to both diagnose and care for. Heart failure could be defined clinically, meaning how does the patient perceive it and how does the physician perceive. So for the patient, it could mean shortness of breath. It could mean fatigue, difficulty with exertion. So specifically, a person may be doing fine at rest watching TV, but walking up to the store or walking to the parking lot may precipitate significant shortness of breath. It can also have significant signs that the physician or the patient may observe. There could be swelling of the extremities, There could be a certain type of heart sounds that is evident on exam, and there could be certain specific types of lung sounds that are evident on exam as well. The disorder may also be defined hemodynamically. And how is that so? It's inability to provide adequate cardiac output to the body at rest or with exertion, or to do so only at the elevated cardiac filling pressures. And these elevated cardiac filling pressures is really one of the genesis for what happens down the road and one of the issue for what ultimately develops heart failure and issues for the heart muscle. Half of patients with heart failure have a preserved ejection fraction, and the remainder display a reduced ejection fraction. And by the end, I hope that everyone will be an expert in the difference between the two. What's the difference? Usually, we think of an ejection fraction as the overall squeezing of the heart, the overall pumping function of the heart. And these two diseases, it's used to be of significant debate. Are they two different diseases, or is it a spectrum of the same disease? And I will show you that it's more likely to be two separate diseases. Systolic heart failure, or dilated heart, as you could see right here on the right, the heart becomes very large, the walls become very thin, and the muscle, the pumping function of the heart decreases. With diastolic heart failure, or heart failure with preserved EF, the opposite is happening. The muscles actually become thick. The myocytes, the actual muscle cells, become much thicker as well, and there's fibrosis around those muscles, so the ventricle becomes very stiff. And I'll show you what it looks like for us on the diagnostic side, on the doctor side, when we look at these patients with an echocardiogram. So to look first at the patient with heart failure with a reduced ejection fraction, what do you see? You see a patient with a very large heart. The chamber itself is large. It's dilated. The muscle, the walls are very thin. And you could see that when the heart is squeezing, they're really not thickening very well. And you could see the same thing here. The muscle itself isn't thickening very well, and it's a big, baggy heart. What happens with a person with a heart failure with preserved ejection fraction? You see the opposite. You could see a big, muscular heart really pumping away here and really pumping away here. And in a reality, this is why for many years, and even up to this day, so many of the patients go undiagnosed, because when we see this on echo, it's very easy to say, well, look, your heart is pumping great. Look at how muscular it is and how well it's pumping. That surely can't be the reason for your shortness of breath. And as I'll show you the data, it probably is the reason for the person's shortness of breath. As we think about the two types of heart failure, it's very important to keep in mind that whether the heart failure has a reduced ejection fraction or whether the ejection fraction is preserved, as you saw in the previous slides, unfortunately, the outcome is very similar. Overall, the patients do very, very poorly. You could see there was some statistical significance, a statistically significant difference between the two populations, with the patients with heart failure with reduced ejection fraction having slightly higher mortality, but the difference is very, very small. And overall, the prognosis is grim for both populations. So how do the two types of heart failure differ? Well, as I said before, it used to be a significant matter of debate. Are they really different? And ultimately, the belief within the cardiology community now is they are indeed two different types of problems. And how did we come to know this? Well, if it were the same problem, you would expect to see one hump, one arch, and you would see the patients with ejection fraction in the middle, and you would see those with higher and those with lower ejection fractions on the sides. And this is not what was actually observed. And in patients who were followed for many years, and this is a study involving close to 5,000 patients, after the analysis of the data, we were able to see that, in fact, there are two types of populations. You have a significant group of people who are on the right and a significant group of people who are on the left. And how do they differ? Well, a big difference is we see that it's women who are in the red and it's men who are in the blue. So for a woman, it's much more likely that she would have a heart failure with a preserved ejection fraction. And for a man who has heart failure, it's much more likely that he has a reduced ejection fraction phenotype. And as a quick aside, one thing that's very interesting as physicians talk to patients about ejection fractions and percentages, everyone always gets worried about not being at 100%. That's not physiological, it's not normal, and it never happens. The norm for your body is to be about 55 to 65% ejection fraction. That's 55 to 65% of the blood in the left ventricle gets ejected with each cycle. Another analysis of the two groups, of the difference between the two groups, was published in the New England Journal of Medicine, and was really quite telling and really set the tone for many years forward. What did we see? The significant findings, and for kind of the basics in statistics, what we want for statistical significance is a p-value of less than 0.05. And here you could see quite values that are significantly lower than that, showing high statistical significance. And what was the difference between the two populations? Well, patients with preserved ejection fraction were older. Patients with preserved ejection fraction tended to be women. They were statistically more likely to be overweight, BMI, and that we'll spend some time talking about that as well. They were more likely to be obese. Significantly, they were more likely to be hypertensive, and hypertension is something we'll focus on as well because it becomes a significant risk factor for developing heart failure with preserved ejection fraction. Patients were more likely to have atrial fibrillation, were less likely to have coronary artery disease, which is a little bit counterintuitive, and I'll show you some slides on that as well. And of course, as expected, this population, the average ejection fraction here was 61, which is really within the normal range, as I said on the previous slide, while the patients with reduced ejection fraction, their ejection fraction was on average 30%, which is significantly lower than normal. This is a very interesting study that I wanted to share, and this is a very insightful analysis of patients with heart failure. And really what was the question asked in the study was, the day before someone was diagnosed with heart failure, what were they like? So in other words, what can we look for in populations to try to figure out who are the populations that we need to target the most in order to prevent the disease? Who are the patients that need our attention the most? And what did we find? We found that it's hypertensives, as I mentioned in the previous slide. Having hypertension increased your chance of developing heart failure with preserved ejection fraction by over 2 times, twofold. Women, so simply being a woman, your risk of developing heart failure with preserved EF was over 2.5 times higher. And just for fun, I included Sheryl Sandberg here. What was interesting is patients with coronary artery disease. These are the patients that really, as a cardiology community, as physicians, these are the patients who we have been most aggressively targeting, most aggressively caring for, most aggressively treating. And these are not the patients who will ultimately go on to develop heart failure with preserved EF, or are significantly less likely to do so. What can we say? What can we say about the trends among the two types of among the two conditions? Well, with heart failure with reduced EF, the number of admissions, of hospital admissions over the last several years, over the last several decades, has been relatively flat. Why is that? Well, it's because our treatments for these patients have been very, very effective. There have been tremendous strides in research and in clinical practice in understanding the disease and also in caring for these patients. However, what can we say about the trend for the patients with heart failure with preserved EF? It hasn't been as positive. In fact, as you can see, the number of admissions had a very clear and statistically significant trend for increase. And why is that? I will show you. The reason is, of course, unfortunately, the treatments have not been there. Part of the reason for the treatments is also the lapse in diagnosis. This small slide, interestingly, it was from a recent review in JAMA Cardiology. This small slide really encapsulates the last 30 years in heart failure research, and it really encapsulates also about several hundred thousands of patients who were under research and in very large, very well-designed clinical trials. And what have we learned? Well, we learned that for this patient populations, again, this is patients with heart failure with reduced ejection fraction, we have made great strides. We know that ACE inhibitors, things like lisinopril, are very, very effective. We know that things like beta blockers, by that I mean metoprolol, carvedilol, are highly effective for these populations. And NNT is the number needed to treat. So you only need to treat 18 patients with an aldosterone antagonist like aldactone to save one life. And in statistical terms and in clinical terms, that's a number that's very, very low, which means that when we prescribe this to the patient, we know that there's a significant benefit that we will be offering to that person and also the population of treated patients as well. We know that there's benefit to starting African American patients on hydralazine and nitrates. We know that there's cardiac resynchronization therapies that we're able to perform for these patients who have certain types of abnormalities within the conduction system. And when we do these, again, we see a very significant improvement in their mortalities. We know that putting in defibrillators, ICD, is again very effective for these patients in terms of saving their lives. The newest player in this arena, the newest agent that we are now able to offer patients is called Artery, which is an angiotensin receptor neprilysin inhibitor, and this is one of the newest agents that we have, again, that showed very great promise and very great and very positive outcomes in clinical trials. Sacubitril valsartan is the generic name. A less disappointing and a less positive slide is here. We, as a community, have been trying for decades to work on patients with heart failure with preserved EF in order to study them and begin to offer treatments. Unfortunately, the results have not been great. This is a list of all of the agents which have been tried, and most of these agents are beneficial for patients with heart failure with reduced EF. The trials here, these are kind of the trial names that always have a kind of a fancy or good sounding title. These are trials that have involved thousands and thousands of patients, and this was at significant expense to the NIH, to various institutions who performed the studies, to the sponsors who sponsored the studies. However, the outcomes have been neutral at best. So there was some talk about sildenafil as it may affect nitric oxide metabolism in the heart, and there was hopes for that. However, the outcome was neutral. Spironolactone, something that is highly beneficial, as I showed in the previous slide, spironolactone again showed to not be beneficial. ARBs, ACE inhibitors, digoxin, things that we know work well for heart failure with reduced ejection fraction, have not panned out, have not worked in this population. Similarly, nebivolol or beta blockers have not been shown to be effective for patients with heart failure with preserved EF, despite the fact that this is the most commonly prescribed medication in this population. So there's a lot of learning that really needs to happen for the clinicians taking care of these patients. So the question that naturally comes up is, where do we go from here? What are we left with? We have a disease. The disease is very serious. It's very deadly. The prognosis is very poor. We've done thousands of clinical trials, or hundreds of clinical trials involving thousands of patients, and at the same time, as I have shown you so far, the results have been poor. So what's the solution? One of the solutions, and one of the ways that we're beginning to really understand the disease, is the actual cure starts many, many years before the onset of the disorder. We know that we need to start screening these patients. We also need to start caring for these patients a lot more diligently, a lot more carefully, a lot earlier on. This is a graph from the All-HAT trial. The All-HAT trial was performed many years ago, but one of the great beauties of the trial was the fact that it involved over 30,000 patients in a randomized fashion. And the patients were assigned to various agents which we commonly use for blood pressure management. Things like lisinopril, things like amlodipine or Norvasc, and things like chlorthalidone, which is a very old thiazide-type diuretic. And what did we see? Well, one thing that's really of significant note, and I highlighted by putting chlorthalidone in red, is that there was a statistically significant difference when a person was treated with chlorthalidone. So using chlorthalidone for blood pressure management in this population decreased the incidence of heart failure. It means that patients who were treated with this agent to manage their blood pressure did better. They did not go on to develop heart failure or developed it at a later age, at a later state. This slide is from a New England Journal of Medicine paper called the HYVET study, H-Y-V-E-T study. And this really addressed a very interesting question. For many years, we were, as physicians, we were kind of resigned to caring for patients who are elderly. The question always was, well, this is a population which has very high blood pressure. Is this a normal part of aging? Is this simply the stiffening of the arteries with age, and this is a normal aging process? Or do we need to be aggressive in treating these patients? Do we need to be aggressive in getting the numbers to go? So this study analyzed patients, nearly 4,000 patients, analyzed patients who were over 80 years old, who were hypertensive. The majority of the patients in the study were over 170 millimeters of mercury blood pressure. And the target here was, let's get them down to below 150. Let's get them down to a little bit closer range to what we hope for the majority of the population. And what did we see? Patients who were in the active group, people who received the diuretic or the ACE inhibitor when needed, did better. Very statistical, very highly statistically significant, and a very marked improvement. You could see these curves diverge really by year 1, and by year 2, 3, and 4, the differences grow out even larger and larger. And so this was one of the trials that really said to the community, patients who are elder still need aggressive blood pressure management. This is a trial that I really wanted to highlight as well today, because this is a trial that I think will influence our guidelines in the coming years, and has really changed the way we view blood pressure management as well. For this trial, the primary results was overall reduction in heart attacks, heart failure, and strokes. And the goal here for these patients, these were all patients who had a blood pressure of above 150, and the patients were divided, or randomized rather, into two groups, an intensive treatment group and a standard treatment group. With the intensive treatment group, the goal was to get them to below 120, which is a relatively good bar, and it's a number that's well accepted as a good goal to have. The other patients were in the standard treatment, where we simply managed them to a goal of 140, 150, and did not increase their blood pressure medications. What did we observe? Well, we observed that overall, patients who were in the intensive treatment group did significantly better. There's a significant amount of nuance to it. To do better and to get to this target, patients required more medications. Patients had additional side effects as a result of these medications. For that reason, there's a significant nuance to taking care of these patients, and it should really be ideally performed by a physician who is comfortable in doing this, who is competent in doing this as well. But if we're able to reduce the blood pressure, and we do it in a way that is tolerable to the patient and does not adversely affect their kidney function, the payoff is great. And what I wanted to highlight specifically is there's an additional specific benefit for patients over 75 years old. And so in this group, there's a high statistical significance in reduction of these events. So there is over 32% reduced risk of having one of these events for an elderly person who was on this intense treatment group. In these kinds of graphs, what you want to be is as far away from 1 as possible, with these 95% confidence intervals away from the point of unity, which is 1. So here you could see that here 67% reduction, or rather 67%, or 30, another way to think of it is a 33% reduction of events in this population. So really very strong numbers. What can we do? Besides blood pressure, we can also focus on our diet. And as I will show over the next 2 slides, there's significant data now that shows we can really improve. We can really make differences in patient outcomes. We can make differences in how long people live, how they feel while they're living with dietary modification. This is a very, very small trial compared to the ones I've shared with you up to now. This is only 12 patients, but these are 12 patients who already have the diagnosis of heart failure with preserved EF. And what was done for these patients? Nothing revolutionary. They were simply placed on a very low sodium diet. In this specific trial, the diet was actually provided for the patients, so the researchers could measure the exact amount of sodium that was provided for them that they took in over 21 days. But the results were there. The results were really, the proof was in the pudding. The diet, this type of diet, which is called the DASH diet, decreased blood pressure significantly by nearly 20 points. And besides a reduction in blood pressure, there was actual clear evidence of changes in the stiffness of the heart. So the hearts actually began to show positive remodeling trends. And so this is simply just all of the patients in the study. And you could see that after treatment, there was a significant reduction in the diastolic stiffness of the myocardium, of the heart itself, which was really promising and very insightful and interesting for us. Very often in clinic, when I speak with various patients, I'm often asked, what diet would I recommend for a person? Regardless of presence or absence of heart failure with reduced or preserved ejection fraction, the only diet that has really been very well validated in very large, very elegant trials, the only type of diet which has been proven to have reductions in heart attacks, reductions in strokes, reduction in the incidence of heart failure is the Mediterranean diet. The Mediterranean diet really focuses on the good types of fats. It really focuses on an increase of olive oil in the diet. And there's even trends that this type of diet has beneficial effects for patients with preserved heart failure, heart failure with preserved ejection fraction. The numbers, specifically in some of these trials, weren't enough to show statistical significance, but there were positive trends in terms of the markers of heart failure and markers of heart disease in these patients. Lastly, we'll talk about exercise. This is maybe the least favorite topic, but the benefits are there, and as I will show you, the benefits are very robust. Again, this is comparatively a relatively small trial, but the reason why was because of how it was done. These were patients, 64 of them, who had a known diagnosis of heart failure with preserved ejection fraction, and patients were randomized to either get intensive therapies or not to get them. And after 3 months of intensive endurance and resistance training, the results were quite marked. The results were very, very good. There was a highly significant trend and improvement in change in VO2. So the maximal aerobic capacity of the patients increased with exercise training. The maximum workload, the amount of force that the heart is able to exert, improved with training. Further, there were significant and favorable changes in the actual echoes of the patients, in the actual dynamics and the actual dimensions of the heart. Positive remodeling, something that is incredibly difficult to achieve in virtually any other means. But we saw changes or reduction in left atrial volume, which is often a signal for how poorly the ventricle beneath it is functioning. So the fact that we were able to show a reduction in left atrial volume is quite significant. This is a trial that, a paper that came out in the Journal of American College of Cardiology earlier this year, and I think this is really a great way to wrap up our talk and to wrap up our discussion. This analysis combined, this was over 50,000 patients, and it combined 3 very large clinical trials that had been done before. And what was the question here? The question was, does exercise matter? Does being overweight matter? That's really the main thing. And the other question was, well, does it matter for one population or the other? Does it matter for patients with heart failure with reduced ejection fraction, or does it matter more for heart failure for patients with preserved ejection fraction? Participants were stratified into guideline recommended categories of leisure time physical activity. What that means is this is activity that you do after work. This is activity not from doing a work every day that's physically demanding, such as a mechanic per se, for example. This is going to the gym. This is running after work. This is running before work. This is going for a swim. This is playing sports on the weekend. So this is leisure time physical activity and BMI. What was shown is leisure time activity in any range was not associated significantly for patients with heart failure with reduced ejection fraction. But, and here's what I think is the most interesting part, specifically for the patients that we have been talking about for the last half hour or so, for patients with heart failure with preserved ejection fraction, patients that really don't have clear guideline treatment options, this information I think is highly significant and really shows us where we should be focusing. What did we see? We saw that patients with a BMI above 25 had an increased risk of developing heart failure with preserved ejection fraction. What did we see before 25? Patients with a BMI lower than 25 had a decreased probability in developing heart failure with preserved ejection fraction. And this line is simply the 95% confidence intervals, and here is the mean. And additionally, the physical activity levels were highly important. And here it really outlines it in a very elegant way. This diagram shows it in a very elegant way. Currently, the World Health Organization and the American Heart Association guideline recommended minimum physical activity is 150 minutes per week of brisk walking, or 75 minutes per week of jogging, much intense activity. And what was shown in this study is a graded response, and one that is highly statistically significant, that with increases in physical activity going from simply the bare minimum to 2 times the bare minimum to 3 times of the guidelines, we see a risk of heart failure with preserved ejection fraction decline. So although this was not seen in patients with heart failure with reduced ejection fraction, for this population that really is very difficult to treat, we see that as this guy was running more and becoming thinner, his risk of heart failure was significantly decreasing. So this topic is really just the beginning of the conversation. This is heart failure, something that takes many books, textbooks to cover, and many hours to discuss as well. It's incredibly rich. There's literally millions of papers devoted to this, and I hope that through this conversation, through this talk, we were able to scratch the surface and introduce some interesting ideas and some novel concepts in the treatment and care of these patients. At a recent Mayo conference talk, I learned of this quote, which I thought was really interesting. Before I came here, I was confused about this subject. Having listened to your lecture, I'm still confused, but on a higher level. So hopefully I didn't add to the confusion, but brought some interesting ideas and interesting thoughts to the conversation and to the forefront. One thing that's important to know is that many physicians, many cardiologists are qualified and are competent in treating these types of patients, in treating heart failure. At UCLA, we have begun a program called the UCLA Shortness of Breath Center, where myself and a partner with a pulmonologist, Dr. Stella Cohen, have been working to study this population in significant detail, with significant depth, and are hoping to be able to contribute and to move the science forward. Thank you very much for joining us. We'll have a few minutes, and I'll be able to answer some of the questions that have come in throughout the study. So the first question is, why study this condition if there's no clear treatment? This is something that, as a cardiology fellow, prior to this, I really thought of myself as well. Well, why devote your time to studying this if there is no treatment? If I've shown you that many people with thousands of patients have worked towards a solution and have not found one. Well, the reason to study it is the burden of the disease. The patient population is overall growing, and the population of patients with this condition will continue to grow as well. So this is an area that really has significant need. And although no clear medical medication has proven to be equivocally effective, as I've shared with you, there's things that we can do for patients to prevent the disease, and things that we can do to modify the course of the disease. By being more aggressive with blood pressure targets, by selecting the right agents to get to those targets, by being more insistent and more careful about exercise and being much more mindful of the importance of exercise, the importance of diet, we could really carry these patients forward, and we can truly help and care for them. The other thing is the proper diagnosis. One thing that I really couldn't delve too deeply in is the difficulty in diagnosing patients with heart failure. Even by the most current guidelines, by the most current standards, about 40% of patients are not diagnosed. The guidelines are only 60% sensitive. So it takes significant skill and significant effort to truly diagnose these patients correctly. Another question that came in is, well, where should the patients go for treatment? Certainly we can help care for these patients at our center at UCLA Cardiology as a whole as well. But this is something that's within the purview of most cardiologists. We happen to focus on this area and develop some hopefully deeper knowledge and insight into these patients. But most cardiologists can at least begin the conversation. That concludes our talk for today. Thank you so much for joining us.